Zack is an associate professor of public health and associate professor of economics at Yale University. As a professor in public health and economics, Zack has produced academic work on the topic areas of competition in hospital insurance markets, surprise out-of-network billing, and the influence of electoral politics on healthcare spending growth. Zack's work has been featured in the Quarterly Journal of Economics and the New England Journal of Medicine. Zack has also presented his research at the White House, the Department of Justice, the Federal Trade Commission, and the Department of Health and Human Services. NIHCM is also proud to have supported some of Zack's research through our grant program. We're so grateful he's with us today to share some of his research. Zack?
Terrific. All right. Well, thanks so much, Catherine. I'm thrilled to be here. And what I want to do today is start by thinking about why do we care about hospital markets? Then I want to talk a little bit about how hospital markets are functioning, some of the trends we're seeing in consolidation. And then I want to talk about what the academic literature shows on the impact of consolidation. And I'll finish a little bit with some discussion of policy and what the options are at our disposal. So, let's just take a step back. It's really important to remember that the hospital sector is an enormous share of GDP, right? It's 6% of the entire economy. And so when we think about what's driving health spending or what contributes to health spending, it's the hospital sector, right? That's the largest single unitary chunk of the health spend. Often I think there's a lot of focus on PBMs or on cost of prescription drugs, and no doubt those are important to look at. The hospital sector is sort of where it's at. That's the big chunk of spending in the system. It's why it's really the focus of my research. We rely on competition in hospital markets to make them function, right? It's really the backbone of the sort of incentives we create for the hospital sector. So in traditional Medicare, we rely on hospitals to compete with one another to drive up quality, right? And the idea here is prices are regulated. Individuals can choose where they go, and that allows hospitals to compete on non-price aspects of care. Medicare Advantage, we're gonna have competition, albeit somewhat constrained, over prices and quality. And then in the private insurance space, we're gonna have competition between hospitals over price and quality. So they're gonna compete on price and quality to join contracts with insurers. And there we're gonna think about these negotiated prices that hospitals negotiate with insurance companies as a sort of a part of their ability to join insurers' networks. So it's worth taking a step back and saying the markets in the healthcare sector are increasingly consolidated. So for context, the Federal Trade Commission, the DOJ, say, look, markets with a Herfindahl-Hirschman index, an HHI of over 2,500 points is highly concentrated, something where we should really pay attention. Most of the healthcare industry has an HHI over 2,500 points. You can see that the average HHI in the US hospital sector is sort of north of about 5,000. 90% of hospital markets are highly concentrated, but we're also seeing concentration high and going up among physicians and also among insurers. Now, the hospital sector has really experienced a pretty significant amount of consolidation over the last 2 decades. So this is a graph, some of the work we've done looking from 2002 to 2017, and there have been north of 1,000 mergers between hospitals. And during that period, there have been pretty few enforcement actions, so 11 by the Federal Trade Commission. And that really follows a period where in the late 90s and early 2000s, the FTC really didn't do many cases, in part because they lost a number of cases in a row. Now they're starting to win cases, but they're really, in my view, going after the most extreme of the mergers. And that's partly because it's hard to win these cases. As I'll talk about later, I think it's partly because the agency itself is doing really well, but they're quite underfunded. Beyond that, one of the challenges is that the Hart-Scott-Rodino Act requires merging parties to notify the government if the deals are of a certain value. Turns out that the majority of hospital mergers are actually under Hart-Scott-Rodino reporting threshold. So I think that the FTC sees them, but there isn't the notification that you'd see in a lot of the big transactions across the economy. So The hospital sector is a big share of the economy. It's the largest single chunk of health spending. The market's concentrated. It's gotten more concentrated because of mergers and acquisitions. And if we look at data from the Bureau of Labor Statistics that looks at prices across industries in the US, we see that prices in the healthcare sector are growing faster than prices in other sectors on average of the economy, and that hospital prices have grown faster than prices in any other sector, even after the Bureau of Labor Statistics attempts to adjust for quality. And the question here is this correlation or causation with a bunch of the consolidation that's happened across the industry? So what we can do is say, well, what is the evidence we have? And I want to think about the evidence on hospital prices and clinical quality, hospital mergers and prices, and then hospital mergers and quality itself. So it turns out measuring the relationship between hospital quality and hospital prices is actually really tough, because it turns out sicker patients in all likelihood like to go to higher priced hospitals. And so I have some work with John Gruber and John Graves, Joe Doyle at MIT, trying to get at this by exploiting the fact that ambulance companies have really strong preferences about where they transport their patients. And so we can build this sort of fancy identification strategy to get the causal effect of going to a high-priced hospital. And our results really surprised me. What we found was that going to a high-priced hospital gets you better outcomes. Right? I was not expecting to see that. And the effects here are really, really big. So moving from the 20th to 80th percentile in prices raises spending on an inpatient admission by about 53%, but it's going to lower mortality by about 37%. Those high prices are going to be cost effective, right? Because they really do have an effect on lowering mortality. But here's what's really, really important. This relationship between prices and quality is only present in markets where there's competition. So if you're in a hospital market where the HHI is 5,000 points, we don't find any relationship between high prices and quality. In those markets, when you go to a high-priced hospital, you just spend more on your care and don't get better outcomes, right? So here, what we're seeing is competition is mediating this relationship between hospital prices and quality. That is, that markets can function in the healthcare sector, conditional on there being competition. So, what about mergers and prices? So the first thing that I think is really, really important to point out is that mergers need to be reviewed on a case-by-case basis, right? We can't just say mergers are good or mergers are bad, and anybody who says that, you just shouldn't listen to. What we can see, however, is that there's a large literature that shows hospital mergers between parties that are close substitutes, that are rivals, can lead to price increases. And so I have work showing that broadly, the closer hospitals are to one another that merge, the bigger the price increases that those mergers generate. We're seeing mergers between for-profits and nonprofits, nonprofits and other nonprofits, and for-profits and other for-profits, all lead to price increases. So it is not true that when nonprofits merge, they somehow sort of step back and say, we're not going to raise our prices. They do, just like for-profits merging. The other thing to keep in mind is that some individual transactions can have very, very large price increases. So Bob Town, who's down at University of Texas, Gautam Gaurasankaran, and Aviv Nebo, who's now actually at the FTC, looked at a proposed merger between Inova and Prince William Hospital. They are predicting that merger would have raised prices by north of 30%. And we see in our data price increases of certain transactions that are extremely large. There's also a growing literature by Limor Daphne, Kate Ho, and Robin Lee, and some others, looking at so-called cross-market mergers. Now, I don't think the name here is totally right. I don't think these are cross-market. I think it's just that the market's really, really big in some cases, and that these mergers can lead to 7 to 10% price increases. And basically, it's these mergers between hospitals that are pretty far apart can raise prices if those facilities share a common insurer. So, what about mergers, quality, and efficiency? So there's a little bit of research on hospital mergers and efficiencies that finds that acquired hospitals can actually reduce their costs by somewhere in the neighborhood of 4 to 7%. However, and this is really, really important, those efficiency gains only come from mergers where the merging parties aren't close competitors, right? So these mergers of hospitals that are 10, 15 miles apart, we don't see any evidence in the academic literature that those mergers are leading to either quality gains or to efficiency improvements. So what about the literature on mergers and quality? I think first it's really important to point out there is literally no academic evidence that I'm aware of that mergers lead the merging parties to raise quality. And so for all of the discussion about this, my sense is if there was something here, somebody would have found it. There have just been studies after studies that have tried to look at this, and nobody's really found anything convincing that when two hospitals merge, their quality goes up. So there's really good work by Limor Daphne and colleagues. It's in the New England Journal of Medicine, finds no systematic changes in mortality. There's been some work looking at the Evanston Northwestern Highland Park merger that found some evidence of quality reductions on some measures. And then there's been work by Corey Capps and others that found some modest evidence potentially of mortality increases post-merger. My sense is to sort of give a summary of the literature, hospital mergers certainly don't improve quality, and there's some evidence that you can see quality reductions. Where there's very, very clear evidence is that hospitals that are more exposed to competition have higher quality, and that exposing hospitals to competition leads to lower mortality. So that's based on work that Mark McClellan and Dan Kessler have done, and some work that I've done and Marty Gaynor has done. The other thing we're seeing is sort of the opposite of monopoly power, it's monopsony power. So we're seeing that when hospitals merge together, that allows them to negotiate lower wages with nurses. And so that's work by Ellie Prager and Matt Schmidt. I'm just going to wind down here. So what can we do then from a policy perspective? So the first is I think we really need to think about stronger antitrust enforcement. So President Biden issued an executive order, gosh, about a year ago on this. I think it was really important to say that. My sense, and I think by most accounts, the FTC is underfunded. I think we really can and should hope for more funding for the agency. I think they're vital in guaranteeing that we avoid transactions that lessen competition. The second is, in some ways, the FTC has its hands tied a bit when they come to looking at hospital mergers and anti-competitive action. So the FTC and the FTC Act don't allow the agency to take action against anti-competitive conduct of nonprofits. So they can look at nonprofit hospitals merging. They can't go after cases for anti-competitive conduct among nonprofits. And I think that needs to change. There's also been some discussion of folks who look at antitrust broadly, thinking about antitrust statutes. So right now, the plaintiffs have to show likely harm to competition. And that's a really, really high standard. And you might think that there are ways we can sort of change the burden of proof, potentially to amending our laws to say that transactions pose an appreciable risk to competition. And from what I understand from attorneys, that's something that we think could meaningfully change things. The FTC has also put out some really good recommendations and proposals to change the reporting requirements for mergers so that more of these deals that are under Hart-Scott-Rodino threshold do actually have to notify the agencies. Taking a step back, okay, antitrust enforcement's good, but there have been a lot of mergers. Most of the market actually is already consolidated, and this big sort of question is, how do you unscramble eggs, right? It's actually really, really hard to unwind mergers. And so I think what we're starting to see is states take action and introduce different forms of price regulation. We see that happening in Oregon and Rhode Island. I think it's great that states are trying. I think we need to study what they're doing and what effects they're having really, really closely, and think about the extent to which price regulation can be something that's effective in markets where there isn't scope for actual competition to maintain market determined rates. So with that, I'll turn it over to back to Catherine.
Thank you, Zach, for sharing the impacts of consolidation and helping us understand the impact on price and quality.